Hey everyone, we're going to continue on talking about our treatment for hypertension. Looking at beta blockers, several indications including obviously hypertension. It's not going to be first line management in a lot of cases. You may use it as an adjunct to other things, but we see that it works best in young patients, especially those that have kind of a high sympathetic nervous system output with a lot of catecholamines and renin. But one of the big problems is that it limits exercise tolerance simply because the heart can't really beat up to the capacity it needs upon exertion. But because of that, we find that it's still useful in the elderly patients. And so looking at the different mechanisms you're going to see here, that in general, when you start a beta blocker, that acutely may not see a ton of effect on mean arterial pressure, but that should lower with time goes on. Cardiac output tends to have a kind of an acute drop typically, and that should remain pretty consistently due to the fact that you're having consistent negative effects on those beta receptors. And then TPR, you may see that total peripheral resistance may increase initially to compensate for that decrease in cardiac output, but will, as time goes on, kind of resort back to baseline essentially. You can also use this for glaucoma, which we've mentioned previously, and then potentially migraine prophylaxis. Propranolol and timolol tend to be the most common ones we've seen being used here. Hyperthyroidism or thyrotoxicosis is another place you may see beta blockers being used. It helps to manage a lot of the symptoms you see with that, including things like tachycardia, anxiety, tremor. But the other big thing it can help with is actually preventing peripheral conversion of T4 to T3, T3 being the more active form of thyroid hormones, kind of an additional benefit to using beta blockers for thyroid storm or thyrotoxicosis. A big place to see beta blockers being used for angina. We're going to talk about this a little bit later on in more detail, so I won't kind of belabor the point here. Just know this will come back up again a little bit later. We'll use this after myocardial infarction, which again, we'll talk more about this later on as well, so that'll kind of come up again. And then we'll talk about it in terms of treating supraventricular arrhythmias. Again, these are things starting above the ventricles, and so they can help slow down the SA and the AV node, which is useful for things like AFib, supraventricular tachycardias, PVCs, things like that can all be very useful. And then you can also use beta blockers for acute panic attacks. So if you imagine someone having like performance anxiety, you have to give a speech. This can be useful to help kind of mitigate some of those central or the sympathetic nervous system effects there. So it helps kind of get the heart rate down, helps them calm down a little bit. And then potentially it can also be used for tremor. So lots of things we can use beta blockers for. And CHF is going to be a big one. We're going to talk about this much more in detail later on. So again, we'll see this again come up in the CHF section. As far as adverse effects go with beta blockers, you want to be careful with bronchoconstriction. Those are mainly going to be in patients like really severe reactive airway disease, and you can mitigate this by using cardioselective beta blockers we mentioned before. So it's like metoprolol, atenolol, drugs like that. And then be aware of the cardiodepressive effects. It's going to have negative inotropy. You can see things like worsened CHF, fatigue, bradycardia. So it's kind of go right along with the mechanism for the drug. You can see for patients with diabetes that can cause hypoglycemia if you have a type 1 diabetic patient, typically due to decreased glucose production from the liver. You can find that beta blockers basically are going to be inhibiting glycogenolysis, which breaks down glycogen to produce new blood sugar. So not only that, but can also mask the symptoms of hypoglycemia. You imagine someone getting hypoglycemic, they get very tachycardic, they get sweaty, they're having tremor. That's a lot of sympathetic nervous system effects. And so if I block that with a beta blocker, then you can find that patient may be hypoglycemic and not really realize it until they start to have kind of the ultramental status and what goes along with that. And then hyperglycemia can be an issue with type 2 diabetics, where you can actually see the beta blockers will depress insulin secretion, which increases our glucose levels. You also see some impaired peripheral circulation with beta blockers, mainly due to some of the effects on blocking beta 2 receptors in the blood vessels. You can see worsening things like Raynaud's phenomenon, skeletal muscle fatigue, things like that. And then we always want to be careful with beta blockers because you can have a sudden withdrawal syndrome, mainly due to constantly blocking those beta receptors. You can have upregulation of them, and when you take away the drug, you can have kind of a marked increase in blood pressure, heart rate. You can precipitate MI, things like that. And then with the highly soluble agents, so you think about propranolol being kind of the prototypical example of this. Worsened depression in some patients can cause pretty vivid nightmares, hallucinations in some. But again, higher lipid solubility means you're going to see more of these effects here. And then additionally, it can also increase your triglycerides. As far as drug interactions go, you're going to find this is primarily going to be due to synergistic effects due to the pharmacology of it. So if you were to mix this with the calcium channel blocker like verapamil or diazem, you're going to find you have synergistic effects on decreasing blood pressure, heart rate. Clonidine, which we'll talk about a little bit later, can do a similar thing where basically you can end up having again decreased blood pressure, heart rate, and you can actually have an issue where you have this abrupt clonidine withdrawal. We'll talk about that a little bit later on, but basically you see really increased blood pressure. Beta blockers can actually help to mitigate some of that. So sometimes you'll use these drugs together, but for the most part, you're just going to be monitoring vital signs to really see if they're having any issues with that. So moving on, we're going to talk about vascular smooth muscles, relaxants, and also alpha blockers. So basically, this group of drugs are going to be alpha-1 adrenergic antagonists, meaning they're blocking the alpha receptors, which is going to help us to cause vasodilation, cause reduction in TPR, and potentially you can even see a reflex increase in heart rate. So good for lowering blood pressure, but can actually increase oxygen demand by the heart. First one I have here is Prazosin. This is going to be a selective alpha-1 antagonist, again specifically used to help lower blood pressure, not usually used by itself, and this kind of goes along with most of these alpha blockers, not used as solo agents, typically added on to other drugs if you cannot get the blood pressure under control by itself. Mainly beta blockers, diuretics, things like that would be common drugs you mix it with. Big thing you see with these alpha blockers, orthostatic hypotension. Patients, especially older ones with kind of poor hemodynamic reserve, when they get up, they're going to have a lot of blood kind of pooling to the feet. They can see headache, drowsiness, issues with syncope. This will be pretty significant for your patients, so be careful with these alpha blockers in that group. As I mentioned, that reflex tachycardia, that can be a problem if you have patients who already have, like, say, poor coronary blood flow and can have more risk for angina, things like that. And you'll also end up seeing some kind of reflex mechanisms like increased renin, increased water and salt retention. The other big thing is sexual dysfunction tends to be pretty potent with these alpha blockers. So again, be careful with that. It may cause a lot of patients to discontinue use. As I mentioned, NSAIDs tend to blunt the effect of antihypertensives, so that remains true here. Using a beta blocker can actually help to synergize with this to worsen postural hypotension, so more risk for falls and syncope. And then you want to be careful in patients with cardiac or renal failure, because again, this can worsen some issues like fluid retention, and it can worsen issues like cardiac reserve and whatnot. There's two other drugs that fit into this category as well as alpha blockers, Prazosin and doxazosin. They are going to have the same indications, same side effects, same everything as Prazosin is. Again, oftentimes antihypertensive agent as an adjunct. You may use it occasionally for benign prostatic hyperplasia or BPH. We're going to find that it's fraught with a lot of side effects when you use it for this indication. We have a drug that is going to be more specific for the prostate that we'll use in just a minute here. And that's going to be Tamsulosin or Flowmax. This actually is going to be antagonizing a specific alpha-1 subtype of receptor. This is alpha-1A. This is found primarily on the prostate, and so you can utilize it to help kind of prevent squeeze on the urethra and help urine blood flow for the urine flow for the patient. I mentioned there's a few beta blockers that have some mixed actions to block alpha receptors, and that's mainly going to be labetalol and carvedilol. So they have some additional ability to lower blood pressure by blocking the alpha-1 receptors. Next up, we have a list of drugs that are called our central sympatholytics, which means they're going to be decreasing the outflow from the sympathetic nervous system. So a couple of different ways this can work, either through these imidazoline receptors or by activating these postsynaptic alpha-2 receptors. Either way, they're going to be decreasing norepinephrine and epinephrine release from the CNS. So probably working at several sites in the brain, but again, the main takeaway from here is just decreasing that sympathetic nerve activity. So if you imagine clonidine being a good example of this class, you can see that it would activate both imidazoline and alpha-2 receptors. This is going to help to decrease the sympathetic ganglia activity, so you have less norepinephrine, which means less activity in the blood vessels, and then less motor nucleus activity on the vagus nerve, which means decreased cardiac output and decreased heart rate. So you can see this has a balanced effect both on causing vasodilation and decreasing heart rate. So generally, decreases TPR, decreases heart rate, and decreases cardiac output. So the advantages of this class of drugs is you can use it for both decreasing that TPR and cardiac output, so it can be beneficial for some patients, and really is going to be possibly effective just by itself as monotherapy, so some people can just be on Clonidine for their hypertension, and tends to work on people independent of race, age, gender, and all that good stuff. So generally, side effects include a lot of drowsiness and sedation, because again, mainly affecting the CNS. You see some dry mouth along with it as well. And you have to be careful as far from a therapeutic index, is that very small changes in dose can have pretty profound effects on the cardiovascular system. This is another big one, along with beta blockers. We have to be really careful with this abrupt withdrawal hypertension. You can have patients on these drugs for a long period of time. You have, upregulation of a lot of these adrenergic receptors. If I block this or remove the drug, all of a sudden you can have very significant withdrawal hypertension, tachycardia, so that can induce MI in some patients. Now, Clonidine is kind of the poster child for this group, as acting again as an alpha-2 agonist, and you're going to find that initially, acutely, you can see some pressor response, meaning it can increase blood pressure, but because of its activities up in the central nervous system, you're going to end up decreasing sympathetic nervous system activity, increasing parasympathetic, to have those kind of negative effects on both heart rate and blood pressure. And then it will increase blood glucose potentially just due to some inhibition of insulin secretion. So a little bit of rise in your blood sugar, but for the most part, it's going to be good as both decreasing cardiac output and TPR. Also has some kind of ancillary effects in decreasing activity of ADH, or antidiuretic hormone, otherwise known as arginine vasopressin. Will also cause some sodium retention, which is why we oftentimes give it the diuretic. You also see some dry mouth, as I mentioned before, some sedation, and interestingly enough, it has some good analgesic activity, which is why you may see it being used occasionally with some opioids for like post-op surgery and things like that. Again, the withdrawal side effects are going to be the primary thing you're worried about, along with some orthostatic hypotension, some impotence, and also risk for bradycardia. Another drug that fits in the same category as Clonidine is going to be Guanfacine, less potent than this one. It's going to be a little bit more selective for the alpha-2 receptor. Occasionally you see some withdrawal syndrome from this, but not nearly as bad as you see with Clonidine for whatever reason, and also a little less sedation. All right, moving on. Our last group here, antihypertensives, will be the direct vasodilators. Generally, these are going to be affecting mostly arteriolar dilation, which will decrease TPR. And you find that you don't use these as primary agents by themselves, mainly due to the fact that there's a lot of reflex sympathetic activation, including tachycardia, fluid retention, increased renin. So these only are going to be useful for kind of short-term treatment of hypertension, not going to be good for kind of long-term maintenance like you see with ACE inhibitors or thiazide diuretic. So the four we're going to look at here is going to include hydralazine, minoxidil, nitroprusside, and diazoxide. Just note that some of them will have a little bit of effect on the veins, but most of them are going to be affecting the arteries. And again, you're going to see a lot of tachycardia associated with these as a reflex mechanism, along with some sodium retention. So some clinical uses for chronic hypertension, you're going to use this as an adjunctive agent. You don't want to use this by themselves. But hydralazine, minoxidil could potentially be used here. And then some of these we're using as an IV agent for a hypertensive crisis. So blood pressure really, really high. You need to get it down to prevent things like stroke, MI. So things like nitroprusside, diazoxide, and Fenoldopam are going to be useful for this. Hydralazine is mentioned being a direct vasodilator. We don't have a firm idea of what the actual mechanism is, but some people think it has to do with increasing cyclic GMP, which will increase nitric oxide production. And we'll see that later when we talk about nitrates, how that works to relax smooth muscle. Also thought to work with some of the renal prostaglandins or interfere with calcium. So again, don't have the full mechanism, but we do know it's good at dropping blood pressure. See here the smooth muscle site, say a smooth muscle cell in the arteries or surrounding the arteries. You can see here by hydralazine affecting things like calcium influx. That can affect constriction by affecting things like cyclic GMP. This is usually going to have a inhibitory effect here. So by blocking or by increasing activity of cyclic GMP, you can have a decreased contraction of that smooth muscle. So lots of different ways this can be affected. Hydralazine, it's important to note that it's acetylated in the liver. This is the enzyme that's going to be metabolizing, and you can have some people who are slow metabolizers, and people who are slow metabolizers tend to hold on to more drug, and they can see what they call this like lupus-like rash, or this hydralazine-induced lupus syndrome. Typically, you see this more in high-dose patients, long-term use, women, and then people are slow accelerators. So you got to be careful with that. And obviously, as far as side effects go, you can end up seeing some hypotension, which can lead to things like headache, dizziness, and flushing. This is going to be contraindicated in patients who either have ischemia, if they're elderly, or they have coronary artery disease. They tend to have less hemodynamic reserve, and you can see pretty dangerous drops in blood pressure with hydralazine, so you have to be careful with that. And then also, it could also turn your stools black. Next, we have Minoxidil. Some people may know this for its over-the-counter topical preparation called Rogaine. This one actually activates some of these potassium channels on the cell. By increasing the amount of potassium leaving the cell, this causes a hyperpolarization and prevents the smooth muscle cell from contracting. So it's actually a muscle relaxing effect due to this increased potassium efflux. So you can see here this channel where it will be activated, it will increase the amount of potassium leaving the cell, which will make it more difficult for the cell to depolarize and cause a contraction. Now, we don't use minoxidil very often as an antihypertensive. As I mentioned, when it was originally being studied, it was found to cause hair growth, which is why we use it as Rogaine as a topical product. And you can actually induce things like MI in certain patients or cause arrhythmias. So again, not very frequently used, but can be used if the patient's failing other therapies or this needs to be added on as like a third or fourth line drug. As I mentioned, the hypertrichosis or the hair growth can be seen when given the drug systemically. You can see it on the face, back, arms, and legs. Whereas with topical use, you can see it just on the areas where you're actually applying it. Next, we have Nitroprusside. This is a very good antihypertensive agent for IV use, typically in the ICU, where you have nitric oxide being attached to these 5 cyanide molecules. Cyanide, obviously, we know being very toxic to the body. We'll see there's a drug we can give to help prevent that. Nice thing here is going to be affecting both the veins and the arterioles in order to cause a very nice balanced vasodilation and reduction in blood pressure. Now, we worry about cyanide toxicity in patients with liver dysfunction. You can see things like acidosis, trembling, vomiting, convulsions. So we give a drug called sodium thiosulfate. This is basically a sulfur donor that can help the liver to metabolize the cyanide and get rid of it. Now, it produces a product called thiocyanate, where if you have buildup of this in patients with renal disease, they can end up seeing things like tinnitus, muscle spasms, psychosis. So be very careful in this with patients with either liver or renal impairment, mainly due to the fact that you have buildups of these toxic metabolites. Next, we have Fenoldopam. This is actually a dopamine 1 receptor agonist. It's going to be primarily working in the kidneys as both a natriuretic and a diuretic, so getting rid of fluid and salt. And it can be used to help manage blood pressure for short terms, usually less than 48 hours. Some issues you can see with Fenoldopam can include things like dysrhythmias, headache, flushing, mainly due to this hypotensive vasodilating kind of effects. Now, the primary thing to note here is that our most current guidelines are the JNC8. They are generally going to be focusing on patients getting a blood pressure goal of less than 140/90. It used to have different goals based on their comorbidities, but whether they have diabetes or chronic kidney disease, generally less than 140/90 is our goal blood pressure for these patients. As far as which medications to choose, you typically will see for Black patients with or without diabetes, they recommend starting on a thiazide diuretic or a calcium channel blocker. They tend to respond better to these drugs due to their kind of salt retentive sort of state. Non-Black population with or without diabetes should be starting on something like a thiazide, calcium channel blocker, ACE inhibitor, or an ARB. Right? Notice here beta blockers are not going to be first-line drugs. Now, if they have any degree of chronic kidney disease, ACE inhibitors or ARBs should be used first, mainly due to their nephroprotective effects. Okay, basically monitor the patient. If they don't achieve their goals within 1 month, you either can increase the dose of the drug or potentially adding on a drug from a different class. Right? Obviously, we don't want to use ARBs and ACE inhibitors at the same time because they're working on the same targets. Not going to be very effective. Okay, so that concludes the section on hypertension. We're going to move on and continue on with part 3 of cardiology. The next thing we're going to talk about here is going to be angina. All right, so just a few definitions. Obviously, ischemic heart disease is when we have this imbalance between myocardial O2 supply and demand. Basically, we can't give enough oxygen to the tissue, thus we end up having signs and symptoms consistent with that. So normally, angina, which is sort of this chest pain, and obviously, as far as coronary heart disease go, generally it's going to be kind of classified as this atherosclerotic narrowing of one or more of the coronary arteries. So this can include things like acute coronary syndromes, like acute MI. Also chronic stable angina, as we'll be talking about right here. So you can see from this picture here that can be several points of failure here, either due to low oxygen concentration at the hemoglobin site. Main thing we're going to be focusing on is going to be this coronary flow and distribution. Usually not an issue with O2 extraction by any means. And then as far as the oxygen requirements, we're going to see the heart rate, wall tension, and this contractile state are going to be really important that we focus on as a means to help to improve what oxygen we can deliver to the heart gets used more effectively. Now, what dictates how much oxygen the myocardium needs is going to be dictated by heart rate, contractility, and this systolic wall tension. Essentially, the increased tension in the heart wall can affect things like ventricular volume and pressures, and it's typically a function of both preload and afterload. Preload obviously being the amount of stretch of the cardiac myocytes prior to contraction, and is going to be dictated by the amount of volume is getting to the ventricle. And then we have afterload, which is that pressure that the heart has to pump against, which can be quantified by that systemic vascular resistance. And so looking at supply of oxygen to the heart, we can obviously see that as a plaque becomes more and more substantial, it's going to be occluding off farther, larger amounts of blood flow to the different areas of the heart. And once you have a rupture, you can end up having a whole thrombosis that forms that can include nearly all of the flow through these vessels. So again, you can see why this gets so dangerous. And the primary thing we want to focus on is try to be preventative in this means, because again, you're not going to have any symptoms up through these kind of early stages, but with a lot of our medication therapy, things like statins and ACE inhibitors, we can hopefully prevent further progression of these plaques and prevent us from ever getting to this stage here. The angina can occur with any degree of stenosis, but typically what you see is that with the left main coronary artery, about 50% occlusion can cause significant symptoms, and about 75% of other vessels. We would consider virtually no flow occurring through arteries that had stenosis greater than 90%. Oh, there's a different type of angina that can occur even that may not be due specifically to these atherosclerotic changes. This is called vasospastic or Prinzmetal angina. Basically, this is due to increased spasticity of the coronary vessels. This could be due to stress, or it could be due to temperature, things like that. But basically, it's this autonomic control where you have spasm of the coronary vessels, which can lead to myocardial ischemia and angina. And so you may or may not see ST segment elevation or any EKG changes here, but you typically see this in younger patients, either during the nighttime or early morning hours. And the treatment will be different for this than we would see with normal coronary heart disease. Now, whenever possible, you want to focus on your modifiable risk factors. So this will be contingent on the non-pharmacologic therapy that is so important for these patients. Things like tobacco cessation, diabetes, sedentary lifestyle. These are obviously things we're going to focus on with your patients, which you'll get more details on in other classes. But we want to focus obviously on the pharmacology and how we can treat this angina. So our goals are to try to increase the quantity of life. We're going to find, and this goes along with all these cardiology topics, that there's some things that are good for symptom management. Some of these things are going to be good as far as mortality benefits go and helping to prolong life. And so it's important to know those distinctions there. And so with angina, we would like to prevent acute coronary syndromes from occurring in the first place. And then we want to also increase their quality of life by helping to relieve symptoms or to prevent symptoms from happening in the first place. So ways we can help manage the O2 demand, we can do things like decrease heart rate, decrease contractility, and then also try to decrease that intramyocardial wall tension. So by either decreasing preload or afterload, we can hopefully help to decrease the amount of oxygen the heart is actually consuming per unit of time. And then for blood flow, getting more oxygen to the heart, we'd like to improve that coronary blood flow. So we're going to see there's different medications that can affect these different aspects. Other things you want to do is try to help stabilize those plaques to prevent acute coronary syndromes and to modify those reversible risk factors. Now, of course, revascularization is probably going to be the most effective thing you can do, although it's going to be the most invasive. This can include things like percutaneous coronary intervention or things like bypass grafting or cabbage. I'm obviously not going to focus on that here since that's not really our purview in pharm, but we'll look at anti-anginal drugs. And again, we'll see these antihypertensive agents come up again and again. And then we'll also look at a few that are going to be called vascular protective. So include things like aspirin, statins, etc. And then obviously the lifestyle changes are also going to be very important here as well. So as far as affecting the myocardial oxygen demand, we're going to see that calcium channel blockers, nitrates, and beta blockers will be your primary agents here. And the things that help us to increase coronary blood flow include, again, calcium channel blockers, nitrates, aspirin, and also another antiplatelet drug I'll talk about a little bit later called clopidogrel. So antianginals should help us to improve exercise capacity, should hopefully reduce those EKG changes that are consistent with acute coronary syndromes, and then help us to decrease frequency of symptoms. So beta blockers, calcium channel blockers, and nitrates are all going to be really useful to help us with this. So again, I'm not going to get super in depth on the classification here, but just note that we are grading our angina based on symptomatology. And so hopefully you can get patients who can go maybe from a class 3 to a class 2 based on, differing medications and trying to tune them up a little bit so that way they, can do more activities before they have chest pain and things like that. Now, primarily beta blockers are going to be good for helping to reduce oxygen demand by decreasing heart rate, decreasing contractility. They can also be useful for helping to decrease that wall tension by decreasing our systolic blood pressure. It may have some effects to actually increase left ventricular volume, so this won't be as clinically important, but these are the three main things that help with demand by the heart. And then we're going to see on the supply side really does not have any direct effect on oxygen supply. So beta blockers are going to be first-line therapy in the absence of contraindications. It's going to be very useful for patients who have hypertension, if they have anxiety, supraventricular arrhythmias, heart failure, post-MI. These are all really good patients who could utilize a beta blocker as a first-line agent as anti-anginal. Typically, you can utilize either a beta-1 selective or non-selective agent. It doesn't really matter. It will depend more on your patient. Obviously, they have severe reactive airway disease. Beta-1 selective is going to be more important there. And we'll see that if they have CHF, there are specific beta blockers that they should be on. And we'll talk about that in a little bit further on in this lecture. As far as contraindications go, they are bradycardic, they have low blood pressure, AV block. These are things you would not want to add a beta blocker on because this could worsen all of those. And obviously be cautious in patients with reactive airway disease, diabetes, PVD. We've talked about all these previously in the hypertension section. Obviously, I'm not going to belabor things like adverse reactions and monitoring because we've covered all that already, but just be aware that all that stuff still applies throughout here. Now moving on to the calcium channel blockers, we can see we have our dihydropyridines and our non-dihydropyridines, and they're going to have different effects on oxygen demand. You're going to find the dihydropyridines tend to have an increase in heart rate, which is not super useful. It really has minimal effects on contractility, but its main thing is going to be decreasing systolic blood pressure. Obviously, it decreases the afterload, have minimal effects on LV volume, but basically the big thing here is you're looking at that decrease in systolic blood pressure. Non-dihydropyridines, though, like verapamil and diltiazem, we know we're going to be more focused on as a cardiodepressant, so it's going to be able to decrease heart rate, decrease contractility, and will also have some effects on systolic blood pressure as well. As far as the supply side, what you find is that calcium channel blockers can be useful for helping to release some of that vasospasm, so this will be good for that Prinzmetal angina I mentioned. And then it can help with some mild dilation in different areas of fixed stenosis, so again, it can help with the supply side. To drill down even further, we're going to see that diltiazem and verapamil are non-dihydropyridines. You're going to have very similar actions here, so nothing really clinically different. But the dihydropyridines are going to be much better at being able to basically decrease blood pressure by having vasodilation, but really should have minimal to no effects on contractility. If anything, can actually increase heart rate, and then really shouldn't affect AV conduction at all. So if you're going to use a calcium channel blocker by itself for angina, this is where you want to use a non-dihydropyridine. You never want to mix a beta blocker and a non-dihydropyridine. More risk to see AV block, hypotension, etc. If you're going to have a beta blocker already on a patient, you can then add on a dihydropyridine. That would make sense. You can do that. Or you can utilize a calcium channel blocker plus a long-acting nitrate, which we'll talk about in a minute. The patients who are going to benefit most from calcium channel blockers for angina include those that are intolerant of beta blockers or have a contraindication. Vasospastic angina, as I mentioned before, peripheral vascular disease, uncontrolled diabetes. These are all going to be good options for them. I mentioned LV dysfunction. This is not going to be for patients, CHF patients, things like that, do not do well with non-dihydropyridines. You could use a dihydropyridine instead, though, so that would be okay. So like amlodopine's fine, verapamil would not. So as I mentioned, as far as drug selection goes, non-dihydropyridine for initial therapy, DHP if it's going to be added onto a beta blocker, and you want to avoid short-acting agents, so things like nifedipine. Typically, amlodipine is a good go-to dihydropyridine you can use there. Contraindications are going to be the same as we would see with treatment for hypertension, but basically be careful if they already have hypotension, bradycardia. If they have acute heart failure, you definitely do not want to use non-dihydropyridine, and if they have poor ejection fraction, similarly. As far as precautions go, be careful with utilizing that non-dihydropyridine and a beta blocker. I've really never seen that combination used before. And then watch out for those CYP3A4 interactions with your non-dihydropyridines. Verapamil and diltiazem will inhibit 3A4. You can see increases in levels of other drugs. Hypotension, headache, flushing, we know the side effects based on our previous lectures. And just, again, the monitoring is not going to be as intensive as you would see with the beta blocker. Really just monitor their vital signs. Next up, we have the nitrates. These are primarily going to be affecting both demand as far as it can decrease systolic blood pressure, because you're going to find these are going to be good for vasodilation. But they can also help to dilate coronary arteries, relieve vasospasm, and have some antithrombotic / antiplatelet effects. Basically, the way the nitrates are going to work is that they can donate nitric oxide, which are going to be going into the vascular smooth muscle cells. They're going to increase activity of cyclic GMP, which is a secondary messenger, and this is going to increase protein kinase G, decrease cytosolic calcium, and having less calcium within the cell is going to cause smooth muscle relaxation, vasodilation, and decreased blood pressure. This will happen to the coronary vessels as well, causing more blood flow, causing better oxygen delivery. It's important to note that cyclic GMP is metabolized by an enzyme called phosphodiesterase, is that PDE. This is the same enzyme that's affected by drugs that we use for erectile dysfunction, like sildenafil, tadalafil. One of the things we'll talk about as far as drug interactions go is that these can work synergistically. Not only is it can increase cyclic GMP production from the nitrate side, but then you block breakdown of it by the phosphodiesterase side. So you can notice there may be some pretty significant hypotension developing between those two when used together. So goals of therapy, we want to relieve acute symptoms of myocardial ischemia, and this is one of the first drugs you'll take if you have acute angina. This can also be used as a prophylactic if you know you're about to exert yourself and you have effort-induced angina. This could be another option. Nitroglycerin itself does not get absorbed from the GI tract very well, which is why we use sublingual administration. So you can either give sublingual nitroglycerin spray, or you can utilize nitroglycerin tablets. Basically, just put this under the tongue. And so we used to recommend dosing these every 5 minutes, and after 3 doses, if you still had symptoms, you would call 911. Nowadays, we go ahead and recommend that you take a dose. After 5 minutes, if you still have chest pain, go ahead and call 911 at that point. As far as patient education goes, make sure they know to be very careful when going from laying down to standing or sitting to standing, because you can see orthostatic hypotension, and they really need to make sure this is stored in the original container, and they have to replace that after 3 to 6 months. And that's mainly because nitroglycerin is a very unstable molecule, and it can break down pretty easily if exposed to sunlight or if it is stuck around for too long. So even if they've only used 1 or 2 tablets out of the bottle, go ahead and have them replaced after 6 months or so. Now we also have long-acting nitrates, and so this is going to be better for kind of long-term kind of maintenance therapy to preventing anginal symptoms from occurring. And you don't use these by themselves typically. You use them as an adjunctive agent onto either a beta blocker or a calcium channel blocker. We have 2 agents here, isosorbide mononitrate and then isosorbide dinitrate. Only difference is how often they're going to be dosed. We also have some topical products. This is an example of Nitrobid, which is going to be nitroglycerin ointment you can apply to the skin. Basically, you would apply your dose, how many ever inches or centimeters long, onto this application paper, and then slap that onto the patient. And that way it prevents, the paper there prevents getting on their clothes or getting onto other surfaces. Typically, we recommend either when dosing a 12 hours on, 12 hours off, and that's important for all nitrates because you can have what we call tachyphylaxis, as I mentioned previously, is that you get to a point where you can kind of exhaust cofactors and other things to where the drug, even if you increase the dose, several times, you'll never get any additional benefit from doing so. So you have to have a 12-hour period, a nitrate-free interval, where the patients can be free of that. They can build up those cofactors again, and then the drug will be effective again. There's also a transdermal patch the patients may also be able to use, again, 12 hours on, 12 hours off. The biggest thing to note as far as adverse reactions go with nitrates is that because they're causing vasodilation, you can see a lot of headache, flushing, and that reflex tachycardia, as we kind of alluded to. So again, tachyphylaxis, the only way to really deal with that is to make sure we have that nitrate-free interval. Typically, you want to do this when the patient is having lowest symptom frequency, which is typically at nighttime when they're sleeping. Now, certainly you want to avoid use of nitrates if patients have a very severe aortic valve stenosis or obstructive cardiomyopathy. But the other big thing to watch out for as drug interactions go is to watch out if they're on a phosphodiesterase inhibitor for erectile dysfunction. It can cause pretty significant hypotension and potentially lead to MI or stroke. So this is a good table to look over. A lot of this will make more sense when we cover some of these other conditions, but basically it kind of tells you what the first line drug is going to be, what the alternative can be as well, if they could not tolerate a first line drug, and then what agents they should avoid based on comorbid conditions. And so just to note, CS stands for cardioselective beta blocker. So for instance, if you have asthma, you can utilize either a cardioselective beta blocker or non-dihydropyridine. The only thing to avoid is non-cardioselective beta blocker. As we'll see with the patient with prior MI, they should be on a beta blocker, as we'll see in a couple slides from now. We talk about acute coronary syndromes, and we'll see why we should avoid calcium channel blockers. And so you can kind of go back and review this to see, like, okay, based on this type of patient, this is the best drug for them for their anginal symptoms. Now, ACE inhibitors are not going to have any effect on anginal symptoms, but they should be used because they can help with things like cardiac remodeling. They can actually help with improving, kind of preventing progression of disease in a lot of these patients. And not only that, they can be useful for diabetic patients and helping to preserve kidney function, etc. So basically, because we know these extend life in patients with cardiac heart disease, coronary heart disease, that this should pretty much be on every single patient with any kind of vascular disease. If you can't utilize an ACE inhibitor, ARB would be fine as an alternative. So again, as far as combo therapy goes, if angina persists with just one drug by itself, you can utilize like a combination of a beta blocker plus a dihydropyridine if they can tolerate it. In some cases, if you need a third agent, if they're still not able to have their symptoms under control, they probably need a bigger workup, something like angiography to look for possible vessels to go under catheterization, things like that. You also want some anti-platelet drugs on board because this helps to prevent those plaques, if they ever do rupture, from having platelets aggregate to them and cause an occlusion. And so aspirin really should be used here in the absence of contraindications. We like aspirin because it's a irreversible COX inhibitor, and so it's going to be affecting the platelets for the duration of their lifespan, which is why you only recommend like a baby dose of aspirin, which is 81 milligrams. So we know that these help to extend life and help to prevent acute coronary syndrome. So this is why we use this as prophylaxis. Now, if the patient cannot tolerate aspirin, you could use alternative drugs. We'll look at some a little bit later on, but something like clopidogrel or Plavix is a brand name can be just as useful. It's just usually more expensive. So again, unless they have a contraindication, they should be on aspirin. They should have a beta blocker on board if they have a prior MI, because we know that extends life as well, as we'll see a little bit. They should be on an ACE inhibitor if they have diabetes especially, or LV dysfunction, some sort of lipid-lowering therapy. And then they'll have a PRN prescription for sublingual nitroglycerin for acute symptoms. And then if they're having kind of daily or more frequent symptoms and they don't have any reason to be on beta blocker previous or something like that, that's when you consider prophylactic therapy with a beta blocker, calcium channel blocker, or long-acting nitrate. Now, that treatment of variant angina, that Prinzmetal angina I mentioned, it can be easily accomplished by using a calcium channel blocker or a nitrate. These are the go-to drugs for that treatment. You typically don't use beta blockers. They tend to lead to worsened symptoms for those patients. Next up, before we talk about acute coronary syndromes, we're going to talk a little bit about drugs that can affect the hematology pathway. And so we're going to start out by talking about antiplatelet agents. So obviously, as far as hemostasis goes, blood needs to remain fluid within the blood vessels. But if we have some sort of break in the vascular endothelium, we need to have it clot quickly. And so once the thrombi occurs, then you have to be able to reestablish fluidity. Otherwise, if thrombi continue to propagate unchecked, you would basically clot off everything and then you'd be dead. So typically what you see early on after you have some injury to the blood vessel is you typically have some vasospasm. This is typically mediated by local mediators like thromboxane. So this causes a vasospasm, it constricts, and then eventually you develop a platelet plug due to different mediators like collagen, things like that. Once the platelets form the plug, you have lots of platelet aggregation happening here. This is where you're going to have activation of our clotting cascade that's going to convert prothrombin into thrombin and eventually fibrinogen into fibrin. This is going to be really important for causing that fibrin clot. And then eventually, once the area is healed, then you can have a breakdown of that fibrin, and where plasma is going to be really important. So we're going to talk about drugs that affect the whole pathway here, from the platelets all the way down to breaking down the fibrin. So as you can see from this slide, it's pretty complicated, but we're going to go through each of these points kind of individually as we talk about different roles of different drugs. So don't get too overwhelmed by this. Just realize that there's different pathways going on here, and by affecting this, we can have pretty profound effects on hemostasis in our patients. So as far as the endothelial surfaces, typically they're pretty well protected from causing thrombi by being smooth. They have these mucopolysaccharides, this glycocalyx layer that prevents platelets from binding onto it. And then we also have on the surface of cells, we have thrombomodulin, and this is important because it binds up to things like thrombin and complexes with, it can actually activate protein C, which can be anticoagulant in nature. And then we also have what we call antithrombin 3, and this is working to bind to thrombin, which we know is a potent influence on causing clots. It can actually help to break it down. And then also a product that our body produces called heparin that actually works by binding to antithrombin 3 and will activate it in a highly accelerated manner, and will inactivate several different clotting factors like 12, 11, 10, and 9. These are really important to make sure these are keeping in check because these help to prevent clots from happening inappropriately. Or if a clot has formed, in the case of antithrombin 3 and heparin, helps to break them down more quickly. Typically, you see agents like prostacyclin can inhibit platelet activation. Thromboxane A2 is going to actually work to stimulate platelet activation. And then we have things like plasmin, which is going to help to digest fibrin, and will also inactivate several clotting factors. So this is important. Once we have a clot kind of not needed anymore, we need plasmin to come along and help to digest that. And we know there's 50 known factors that affect coagulation, both in a pro and anti-coagulation kind of sense. And so we'll talk about these more in detail, but these are kind of the primary players we're going to be talking about for now. So obviously clot formation, this is a picture of several red blood cells getting involved with some platelets and fibrin strands. And this is kind of what's occurring when you have a vessel that's either had a ruptured plaque or if you have any kind of vascular injury, what the process is for causing that clot to form. So typically platelets are kind of this nice kind of globular shape here. They are going to be inactive in their normal state. What will happen is we're going to see when you have vascular injury, either a plaque rupture or something like that, that you're going to have platelet activation. Basically things like von Willebrand's factor is going to be important for causing a change in the conformation of the platelets. They kind of change their shape a little bit, and you're going to see that they can start to be activated. And based on this pathway, you're going to see that they tend to aggregate with one another via specific receptors, as we'll see in just a few minutes here. Now, when platelets get exposed to collagen, they can end up binding to a product called von Willebrand factor. They'll be there at the site of endothelium. And then you're also going to have some release of products like thromboxane A2 and also adenosine diphosphate or ADP. Now, this thromboxane A2 and ADP are going to cause this conformational change of the platelet to expose a receptor called 2B3A. And again, you're going to be thinking like, why the heck do we keep talking about these acronyms? This will become more important when we get into details of different drugs that affect these in a few minutes. Basically, when you have the 2B3A receptor that's exposed, it's going to cause cross-linking of the platelets by fibrinogen. Next, you're going to have a product called thrombin, which can interact with these receptors called PAR1 and PAR4 that actually stimulate platelet activation as well. And then you're also going to have ADP activating these P2Y1, P2Y12 receptors, which will also activate platelets. So there's several different pathways that happen here. So even if one was inhibited, you can still have some activity with the other pathways. So again, imagine a platelet here. Notice that 2B3A receptors are really important for fibrinogen to bind to cause cross-linking to form the aggregation of platelets. Obviously, collagen is going to have a positive effect here. We're going to see things like thromboxane A2 are going to be affecting this. ADP, thrombin, serotonin, epinephrine. So lots of different factors affecting the platelet. We're going to look at specific drugs and how they can be affected. Here's just a picture showing what a platelet would look like before activation versus when they are activated by things like that von Willebrand's factor, and they're showing their 2B3A receptors. See how they're much more sticky, kind of grab onto one another and stick there together. So how do we inhibit platelet activation? Several things we can do. Typically, the body produces prostacyclin or PGI2, and that gets secreted by the endothelium and has a natural platelet inhibiting effect. Typically, collagen is also not exposed when covered by the endothelium, and we have relatively low levels of thrombin circulating in general. Right, so all these things help to prevent platelet activation, and platelets don't tend to express the 2B3A receptors on the surface unless they've had that conformational change occur. So all these things are good because they help to prevent platelets from aggregating up where they're not wanted. So you can see here normally things like collagen not usually being exposed to the platelets that prevents activation. These receptors are not available on the surface, and then thrombin itself just isn't really in high levels if you have a normal, healthy, uninjured vascular endothelium. So one of the first drugs we can use to help pharmacologically inhibit platelets is going to be aspirin. And we talked about this previously, but we know it's irreversibly acetylating that COX enzyme. And so for the life of that platelet, around 7 to 10 days or so, you're inhibiting that production of thromboxane A2, which we said was going to be a platelet and try to activate platelets. You also see a little bit of effect from inhibiting PGI2 partially in the endothelium, but the main thing you're going to notice here as far as dosing goes is that we can inhibit COX maximally at relatively low doses. So even just 160 milligrams a day is totally fine. A lot of people end up just taking like 81 milligrams a day to one baby aspirin, and they can generally achieve pretty good activity. So we've looked at pictures like this previously, where basically you have cyclooxygenase, affecting this arachidonic acid, producing several products, including thromboxane A2, which again we saw was going to be proplatelet, but also prostacyclin, which typically has inhibitory effects on the platelet. So it's a delicate balance, but typically when you have a vascular injury occurring, thromboxane A2 tends to get kind of upregulated and is formed in higher proportions. We know aspirin is a non-selective COX inhibitor, affects 1 and 2, and so COX-2 is going to be expressed in the endothelial cells and also with inflammation as well. So that's one that's inducible, and so that prostacyclin in humans is one that's going to be anti-platelet activation, and so it's important that we have kind of a balanced effect here, because if, for instance, you had just a COX-2 inhibitor, that would actually end up blocking a lot of prostacyclin but not thromboxane, so you can end up seeing kind of an increased effect on platelets activation. And this is the reason why COX-2 inhibitors got removed from the market, because they were actually causing people to die from these cardiovascular events due to this imbalance. So looking at the effects of NSAIDs, the reason why we like aspirin is because its effects stick around for so much longer due to that irreversibility. Things like ibuprofen maybe only around for 24 hours. And so once the drugs are gone out of the system, you don't see any additional anti-platelet effects. And so these are not going to be good for cardioprotection. Really, aspirin's the go-to drug there. Obviously, with aspirin and other NSAIDs, GI effects can be important here, because they actually help to decrease that gastric barrier that protects the stomach from its own acids. And so for more chronic use, you can certainly see bleeding in the GI tract and also bruising in several patients. Another drug you may see being used as an antiplatelet drug is called dipyridamole, or Persantine is a brand name. It also works as a vasodilator and is occasionally mixed in with aspirin to form a product called Agranox. And this is actually used in treatment of transient ischemic attacks or ischemic stroke. Not used super commonly, but just know that it can be used occasionally as an antiplatelet drug, mainly working by inhibiting adenosine uptake, so you don't produce as much adenosine diphosphate. And so we'll see that's going to be important for another group of drugs here in just a few minutes. Next up, we're going to be focusing on drugs that are affecting the ADP receptor, which you can see right here. So we're going to have a couple drugs in this category that are going to be affecting this. So these drugs are going to work to block ADP from binding to several platelet receptors, including this P2Y1 and P2Y12. They're working through a little different mechanism here, but the important thing is that by blocking both receptors, you're going to find that you have pretty decent effect at blocking platelet aggregation, because you kind of need both to be working actively to cause the platelets to activate appropriately. And then you also see a little bit of direct inhibition of fibrinogen binding to those 2B3A receptors, and also can help to interfere with the binding of von Willebrand factor. We found that was important happen when the collagen was exposed during the endothelial injury. We have a couple of drugs here. Clopidogrel is probably the most common one I've seen being used. There's also Clopidine, Ticagrelor, and then Prazosin. I'm starting to see increased utilization of Ticagrelor and Prazosin as of late, especially when used with cardiac catheterization, as we'll see here in a second. But basically what you're going to find is that it can be synergistic with aspirin, because again, it's working through a few different mechanisms here. It can have pretty good effects to block that platelet activation. And so you're going to see this most often either to help prevent stroke, MI, or after angioplasty in a lot of cases. So the first one we'll talk about is this ticlopidine. This one, again, working primarily as a inhibitor of this P2Y12 receptor. It also forms a kind of disulfide bridge, which inactivates it. Main side effects you're going to be seeing here include hemorrhage, obviously, due to the antiplatelet activity. And the reason why we don't use this one so often anymore is due to this thrombocytopenic purpura that can happen here. It's an immunologic condition that can be pretty severe, pretty deadly in a lot of cases. So not super commonly used, but it was probably one of the first ones we had out there. Clopidogrel, though, is a very common one. Again, this one's going to be working on that P2Y12 receptor, very synergistic with aspirin. And because it takes a while for it to really kick in, we do loading doses with this one. So you may see someone get a big loading dose of Clopidogrel or Plavix before getting put on a lower maintenance dose. Obviously, hemorrhage, neutropenia are small risks, and CTP risk is much, much lower than with Clopidine, which is why it got used much more commonly. Next up, we have Prazosin. Again, very similar mechanism, still synergistic with aspirin. And now what we're actually starting to see with some of the studies is that it's starting to get recommended over Clopidogrel due to even more platelet inhibitions, more effective than Clopidogrel is. As far as side effects go, it is obviously bleeding risk is a risk here, and then possibly some increased effects on raising blood pressure, hyperlipidemia, etc. So you would want to monitor for that in your patients. And then finally, we have Ticagrelor. This one is going to be, again, binding to that P2Y12 receptor. Notice it also gets recommended over Clopidogrel due to platelet inhibition effects, so again, to be a little bit more effective here. But obviously, the more effective it is at blocking platelets, the more likely you are to see bleeding as a side effect. So major bleeding can happen in between 4 to 12% of patients, so again, pretty significant. Dyspnea, and then increased uric acid, so it could be bad for your gout patients. And the last group we'll talk about here for platelet activation is going to be our 2B3A receptor antagonist. So the first one we have here is Apixaban. Obviously, you can tell by the name that it's a monoclonal antibody. You find the 2B3A inhibitors are typically going to be given via IV infusions. These are typically going to be used around the time that a patient is going to the cath lab, whereas the ADP receptor antagonists tend to be oral medications that are going to be used more for a chronic basis. But basically, this is a monoclonal antibody designed to target that 2B3A receptor. And again, it's pretty expensive, but it's nice because it sticks around for some period of time after the surgery is done, essentially. You will see this used most often with aspirin and heparin. It helps to prevent restenosis of a vessel that you've gone in and opened up manually. Obviously, risk of bleeding is going to be the biggest thing here, and then also some risk, especially if you have repeated usage. Some people can develop antibodies, which might make you more likely to have a reaction to it. Another 2B3A blocker is going to be Eptifibatide or Integralin. Again, this is a similar inhibitor of preventing fibrinogen from binding that 2B3A receptor. Again, you oftentimes use with aspirin and heparin during acute coronary events or during angioplasty. It's very similar side effects to Apixaban, only less immunogenicity here because it's not a monoclonal antibody, which is a beneficial component to it. So maybe if someone had been on Apixaban previously, you're worried about antibodies, this might be a good option to switch them over to. We also have Tirofiban or Aggrastat. This is, again, a non-peptide inhibitor, so again, lower risk for having allergic reactions to it. Very similarly used to Integralin and ReaPro, but basically same risk here with bleeding and some risk for things like bradycardia, dizziness, but not super common. All right, so those are all of our antiplatelet drugs. Let's move on now, talk about things that are going to be considered anticoagulants. So I'm sure you guys have seen a picture like this before, but this is basically our clotting cascade. Some important things to note here is we have two main systems, the intrinsic system and the extrinsic system. Both of these are going to be activated pretty equally in our cases of thrombosis due to acute coronary syndrome, things like that. Just note here that you're also going to have different measurements of how these systems are working. Typically with the intrinsic system, you're measuring things like APTT versus PTINR for your extrinsic pathway. Just note that it culminates in this kind of common pathway where you have factor 10 being activated, activating factor 2, otherwise known as thrombin, and that thrombin converting fibrinogen over to fibrin. Okay, so again, that soluble fibrin, that's what's helping to bind all those platelets together and forming that kind of strong clot that we see there. Obviously, we can't have this happening kind of unchecked. It's important we have natural anticoagulants. So this is where things like thrombomodulin is really important here. Antithrombin 3 is going to be really important with respect to heparin. And so we'll see that different pathways can be affected, and we'll see that different inhibitors can be utilized. Drugs can affect this, and hopefully to help prevent having too much clotting versus too little clotting, as we'll see with different anticoagulants. So the first anticoagulant we'll talk about here is called heparin, which is found in many cells like our mast cells, and is basically going to be this kind of long sugar molecule, as you'll see here. And so this is kind of unfractionated heparin is another name for this. It can range in pretty wide range, between say 3,000 to 30,000 Daltons. So again, you have long chains, you have short chains. This is important to note. This is the unfractionated heparin because when we talk about low molecular weight heparins, they'll be different in activity, as we'll see in just a minute. Basically, the way they're going to be working is that they will bind and help antithrombin 3 work better against inactivating factors 2, 10, which we mentioned in that common pathway, 9, 11, and 12. So these are the main factors that get inhibited by unfractionated heparin. We'll see how that will differ when we look at our low molecular weight heparins in a second. But basically, it's working with antithrombin 3 to help that enzyme work more effectively. Can increase that activity by about 1,000-fold here. So once the factors are inactivated, then basically they cannot continue to participate in the clotting cascade, and so hopefully you should have less clotting occurring here. And again, once you typically find that antithrombin 3 is activated and it's kind of bound to thrombin, that's when you end up seeing the heparin gets released and they can go on and bind up over to another molecule, antithrombin 3. So these are kind of reusable as long as they're finding antithrombin 3 to bind to, and they can help to degrade these different factors. So just kind of show you an idea of what the unfractionated heparin kind of looks like, a long chain. Here's that antithrombin enzyme. It will come along and bind to that. Here's say activated 10A. Here's activated 2A or thrombin. Notice here how heparin can help antithrombin 3 to inactivate both of these, right? So it's long enough of a chain they can still work with both of these molecules. And again, unfractionated heparin is helping antithrombin to work much, much more quickly than it could by itself. So the unfractionated heparin, typically what we see, our medicinal products we have is that isolated from things like porcine, intestinal mucosa, things like that. And we can't give it orally because it gets degraded by the GI tract. So we have to either give this sub-Q or give an IV. This is actually preferred in pregnancy because it doesn't cross the placenta, it doesn't cross into breast milk, which those are nice things there. And the other thing is that typically IV has a short half-life, so you have to give it via continuous infusion, usually following a bolus of heparin to try to get your levels in range. And so typically the half-life can vary, but patients with renal failure or cirrhosis, they can tend to have an increased half-life and maybe have a prolonged or a more pronounced anticoagulant effect. And the way we measure the efficacy of unfractionated heparins by monitoring the APTT, or the activated partial thromboplastin time. Basically what you're looking for is a ratio between, say, a normal APTT level and the patient's APTT, and it usually is around 1.5 to 2.5 or so. The main places we're going to use unfractionated heparin include if we have venous thrombosis, pulmonary embolism, NI, coronary angioplasty. Anytime you need to make sure a patient's anticoagulated, heparin can be a very effective drug to use that. And again, primarily going to be used in the more inpatient hospital side. Now, the major toxicity obviously is going to be bleeding. We can actually reverse that with an agent called protamine. Protamine will bind up to the heparin and actually prevent it from working more effectively. Another really noteworthy side effect of heparin is what we call a heparin-induced thrombocytopenia, or HIT, and this is a very rare thing. Maybe 0.5% of patients may experience this. And basically what will happen is your patient's on heparin for several days, say 5 to 10 days or so, and they start to develop this antibody that will bind to heparin and another molecule called platelet factor 4, and this actually works to activate platelets. So you have these patients who are on heparin all of a sudden activate all these different platelets, and they can end up causing a thrombocytopenia, but they're also clotting all over. So it's very, very potentially deadly. And we use some direct thrombin inhibitors, which we'll see just a little bit later on, including lepirudin, ergotraban, and dineperoid. Basically, patients who get HIT, they are precluded from using any heparin-based products because as soon as they are given that drug again, it could potentially occur all over. So that falls into the low molecular weight heparins, which are basically just kind of chopped up molecules of heparin. They're shorter in length. And so we're going to see it has some effects on their activity. The primary ones we're going to see here include enoxaparin or Lovenox. This is the most common one I've ever seen. Dalteparin and tenzaparin would also be in this category as well. Basically, they lack the ability to really affect factor 2A or thrombin because they're a shorter molecule. That basically prevents it from really binding with antithrombin 3 and affecting thrombin, but certainly factor 10A is going to be affected very well. So looking at the ratio of 10A to 2A activity with unfractionated heparin, it's about 1:1. With low molecular weight heparin, it can affect a little bit of factor 2A, but mainly it's going to be focusing on factor 10A. Okay, so this is the primary thing to look at, and that's why we'll see that the monitoring changes as well. So looking at a low molecular weight heparin, basically it's a shorter chain molecule. It can bind to activated 10A and antithrombin. It binds okay and can break that down, but because it can't really bind conformationally to the 2A very well, that's where you can see it doesn't really work all that nicely. It can affect it to some degree, but not nearly as much as factor 10A. So low molecular weight heparins are going to be given just about any place you can give heparin. You can give a low molecular weight heparin, typically given as a sub-Q dose, and you find that typically has a longer half-life, which is nice. So you don't have to give, enoxaparin via a IV infusion or anything like that. Usually you just give it twice a day in a lot of cases. Now note here, you cannot monitor APTT for low molecular weight heparins. You have to monitor another enzyme assay called anti-factor 10A activity. This basically tells us how well we're affecting 10A, and we can use this more often in patients who say have, have obesity or very young children. You can utilize this assay to make sure it's working very well. The nice thing about it though is if you're giving it to a relatively healthy adult, you don't have to do any monitoring. You don't have to monitor APTTs like you do for heparin pretty consistently. You can just give it to a patient, and generally they're not going to have any issues with it. You do want to note those that it is eliminated primarily with the kidneys. Usually regular heparin is going to be more kind of liver mediated as far as metabolism goes. You don't have to worry about renal function quite so much there. But here, these patients, it is almost entirely renally eliminated. So if you have renal failure, drugs going to stick around for longer, and then you run the risk of having increased risk for bleeding. Now, typically less bleeding occurs here with these low molecular heparins than with heparin itself, but it can also cause HIT. So a patient who has HIT with heparin, you do not want to give them a low molecular weight heparin. We have another drug that's even shorter molecule than the low molecular weight heparins. This is called fondaparinux or Arixtra. This is actually just a pentasaccharide. It's only 5 sugar molecules long. And so it is a very, very selective inhibitor of 10A, has almost no effect on 2A whatsoever. And so similar to low molecular weight heparins given sub-Q, do not want to use it in renal failure, do that renal elimination, and a very low incidence of HIT, almost never causes HIT in those cases. And again, similar uses for low molecular weight heparins and heparin. Knee and hip replacement, pulmonary embolism. Anytime you don't want a patient to cause a clot, this is going to be a good drug to use. We have another group of drugs called the direct thrombin inhibitors. So these are going to be drugs that are actually going to be based off of natural products from the salivary glands of leeches, a product called Hydralazine. And so these work directly to bind and prevent thrombin or factor 2A from working. We have a couple IV agents, including lepirudin, bivalirudin, or ergotraban. Notice here that you can monitor APTT levels because it's affecting 2A specifically. And a lot of times we use these drugs when a patient cannot receive heparin if they have HIT. This is a good drug to use instead. All right, another major anticoagulant we have here is called warfarin. This is originally used as a rodenticide and to kill rodents and things like that, but we realize it has a very good activity at preventing clotting from occurring, and so we used to use it much more frequently for things like prevention of clots and AFib, etc. Starting to be supplanted by some of our newer anticoagulant drugs, but you may still see a large number of patients who are being treated with warfarin. Basically, the way that it works is a vitamin K antagonist. Basically, it prevents vitamin K from being utilized within the liver in order to form several clotting factors. And so the main ones that get affected here include 2, 7, 9, and 10. So again, notice 2 and 10 are affected here, and we saw those were important in heparin activity. Basically, without this vitamin K to be recycled, you prevent production of those clotting factors, and thus you're less likely to cause a clot to form. So again, a nice picture here showing you the utilization of vitamin K. Basically, you start off with an oxidized form. As vitamin K epoxide reductase is utilized to help kind of recycle that vitamin K and help to form new clotting factors. Warfarin will inhibit this and prevent that from being utilized. You can't recycle vitamin K, thus cannot form new clotting factors. So we see at therapeutic levels, warfarin can drop down vitamin K dependent synthesis of those cofactors by about 30 to 50%. And so it does not do anything for any clotting factors that have already been produced and released into the bloodstream, and so that causes it to have a delaying effect. It can take 3 to 5 days or so before warfarin really kind of kicks in because it only blocks production of new clotting enzymes. So looking at this, you can see it takes several hours to days for many of these clotting factors to be broken down over time. So even though you may see some anticoagulant effect within the first 24 hours, it can take 3 to 5 days, as I mentioned, really to have the full effect here. Even 5 to 7 days in some cases if you have a hard time getting them up to goal initially. So warfarin is only given orally, has a good absorption, and you'll find steady state to be about within 3 to 5 days or so. Important things to note here is that they have 2 different enantiomers here. Liver metabolism is obviously pretty important. So the S enantiomer, which tend to be more potent, is going to be inhibited or metabolized by CYP2C9, and then the R enantiomer is metabolized by 1A2 and 3A4. So you can see here how drug interactions will be very important here. You have someone who blocks or drug that blocks CYP2C9 metabolism. You could have a buildup of warfarin, could cause higher anticoagulant effects and cause bleeding to be a risk. Warfarin is not going to be used in pregnancy. Heparin actually gets recommended over warfarin if you had someone who is in a hypercoagulable state. So it's actually category, I believe it's category D, but it might even be excellent in a lot of cases. So it depends on the reference you're looking at. So lots of interactions to worry about with warfarin. The big thing here is things that can decrease the actions of warfarin. So we can see things that affect uptake and metabolism of vitamin K. So this is a really important thing for patients to note, is that they have to keep their diet relatively consistent as far as vitamin K intake goes. A lot of things like green leafy vegetables have high amounts of vitamin K in them. If a patient all of a sudden starts to ingest, say 5 spinach salads a week, that can be a lot of vitamin K and can make it very difficult for warfarin to work. This is a big thing to note there. If they all of a sudden drop their vitamin K intake and they have no salads whatsoever, then all of a sudden warfarin is going to be working way too well because you have less vitamin K hitting the liver, and thus warfarin is going to be able to have a bigger effect at blocking those clotting factors. So vitamin K intake is very, very important to educate patients on when they are taking warfarin. Other things that can increase the actions of warfarin include CYP2C9 inhibition. If you had a drug that kicked warfarin off of albumin, you get a protein binding interaction. And then also as I mentioned, decrease in vitamin K intake. Sometimes you'll actually see that bacteria are useful for helping to process vitamin K to help us to absorb it. So sometimes antibiotics can actually help to get rid of that gut flora and can lead us to have less vitamin K absorption. So that would make warfarin work better. So the way we monitor warfarin is with our PT-INR. Basically, this is going to be, INR stands for that international normalized ratio, where basically we're looking at the patient's PT versus the reference PT, and you end up getting basically a number that's spit out for your INR. And typically what you're shooting for is 2 to 3 for INR for most normal patients, and then for some we'll see rarely you shoot for 2.5 to 3.5. Now, patients who require that higher INR of 2.5 to 3.5 include patients who have, say, warfarin resistance for whatever reason, or if they have a mechanical heart valve, they tend to be more likely to clot off than patients with, say, a normal valve. So again, 2.5 to 3.5 for these patients. Otherwise, 2 to 3 INR is typically pretty well recommended. Some patients are going to have a hypersensitivity to, or not hypersensitivity, but a higher sensitivity to warfarin, in which case it's because they end up having these alterations in their CYP2C9, which means they don't metabolize the drug as well, which basically means that around 10 to 20% of Caucasians will have low functioning CYP2C9, and thus warfarin levels will be higher. Thus is more likely to cause anticoagulant effects and less bleeding. So bleeding is going to be the biggest thing to watch out for. If you have a INR within the goal range, less than 5% of people should have really clinically significant bleeding. But as the INR goes up and it's say greater than 4, you see increased risk for cranial hemorrhage. If it gets greater than 5, this is where you need to start worrying about pretty serious bleeding. The way that we reverse this is going to be with vitamin K. So you can actually give vitamin K, and this will help to replenish what's in the liver, will help to produce new clotting factors. This is pretty slow because it takes time for the liver to utilize that vitamin K to make new clotting factors. So what we can do even sooner, if they're having serious bleeding, like GI bleed or intracranial hemorrhage, you can actually give fresh frozen plasma, which is replete with several clotting factors already. Now, obviously, is not recommended in pregnancy, so you can see birth defects with it. And then some patients actually will have this kind of skin necrosis that happens. So you can see these kind of dark blotchy areas on the skin, and patients have a protein CRS deficiency. So again, with warfarin, it's very highly dependent on their diet. They really need to keep a consistent intake of green leafy vegetables and other foods that contain vitamin K. And so it's highly diet dependent. You can have patients have wildly different INRs from week to week based on their diet. You have to monitor it pretty frequently. There's lots of drug interactions. And the benefit, though, is it's easily reversible with vitamin K and fresh frozen plasma. So to try to get an alternative, something we don't have to monitor as much, we have new drugs called our new oral anticoagulants or novel oral anticoagulants, NOACs. And so this is going to include drugs like dabigatran, rivaroxaban, and apixaban. So dabigatran was one of the first new oral anticoagulants that came out. Brand is Pradaxa. Basically, this is a direct thrombin inhibitor. So this works similar to what we saw like bivalirudin previously, where by blocking thrombin activity or factor 2A, you can end up seeing pretty significant anticoagulant effects, prevents that fibrinogen to fibrin conversion. And so we can use it for things like DVT, pulmonary embolism, atrial fibrillation. The nice thing here is there's no real monitoring associated with it. You don't have to monitor APTT, you don't have to monitor PTINR, anything like that. The only adverse reactions there's bleeding risk, right? There's really no good available antidote like vitamin K available. They're actually starting to make now a monoclonal antibody that can bind up to dabigatran, but it's very expensive. And so it's some big issues there. Also, it's renally eliminated, so it needs to, you have to watch out for a patient's renal function to make sure you're adjusting that dose appropriately. Otherwise, it can come back in with a big bleed. Next, we have rivaroxaban, or Xarelto. This one's actually going to be a direct 10A inhibitor, so this is going to be more similar to apixaban as we saw previously. Similar indications to dabigatran, DVT, AFib, PE, and again, no monitoring noticed here. Now, because this one is a direct 10A inhibitor instead of a 2A inhibitor, this one can be possibly reversed by what we call a prothrombin complex concentrate. Basically contains a ton of clotting factors, including thrombin. Prothrombin gets converted into thrombin. And so basically this is very useful because it can kind of bypass that 10A enzyme essentially, or 10A clotting factor. This one again is renally excreted, but there's no dosing recommendations to adjust for that. Next, we have apixaban, which is another 10A inhibitor, similar to the rivaroxaban. Similar indications, no monitoring that can be routinely recommended. The only thing to note here is it is metabolized by CYP3A4, so you would want to watch out for those drug interactions if you did have an inhibitor on board. All right, so that's all the anticoagulant agents we have. We're going to talk about these again in conjunction with how we are dealing with acute coronary syndromes. And so we know these to be basically blockages of the coronary vessels leading to myocardial ischemia. There's several variants here. We have things like unstable angina. We have non-ST elevation MI. These are considered non-ST segment elevated ACS. And then there's ST segment elevated MI or STEMI. And so essentially what we're seeing here, we've already kind of looked at this previously, is that when you have a normal atherosclerotic plaque, typically it's covered up by this fibrous cap. Well, if that were to rupture, if you were to have, say, a balloon deployment here, say during catheterization, you can injure that endothelium. That is going to start to draw platelets. You're going to have adhesion and activation thereof because, again, collagen is exposed, von Willebrand's factor, all of that's going to start to activate the platelets. Once you have platelet activation, then you're also going to start to get fibrin brought in here, and so you can start to see how this is going to start to be occluded off and less oxygen-rich blood can flow to the myocardium. Here we now have an occlusive thrombus. So I've already mentioned how thrombin's a big link between both activating our platelets and also going to be important for the rest of the clotting cascade. So certainly with collagen exposed, we see things like thromboxane and ADP leading that platelet activation and aggregation, but thrombin is also going to be another potent factor here as well, right? So the things we see when we have the thrombus formation, obviously, is that when that tissue factor, which is part of that extrinsic pathway, is activating things like factors 10 and 2, that can lead to thrombin activation, which is going to lead to fibrinogen being converted over to fibrin and also activate those platelets. Here we can see how thrombin is going to be affecting this kind of amplification step where it's going to be affecting the platelets, causing them to activate and aggregate together. And we also see in the pathway that thrombin can actually feed back and start to activate earlier stages in the clotting cascade to cause kind of a positive feedback loop. And finally, you have this propagation step where the majority of thrombin being formed here is going to lead to this conversion of fibrinogen over to fibrin. And this is where you have the kind of clot stabilization that occurs here. We have the kind of this nice stable clot that's occluding that vessel. So when you have these occlusions, the goal here is to try to establish coronary blood flow. You want to relieve that chest pain they're experiencing and prevent a progression over to MI if it hasn't already happened. Obviously, we want to prevent development of heart failure and then prevent death if at all possible. So treatment ACS is going to be focused mainly on pharmacologic therapy, and you'll see that they're going to have some common characteristics here between STEMI and non-STEMI. First off, aspirin is going to be recommended the first signs of chest pain. Even if they take a daily 81 milligram aspirin, we recommend they chew and swallow 325 milligrams. This helps to reduce mortality and reinfarction. Nitrates, on the other hand, even though they provide symptomatic chest pain relief, as we saw previously in angina, they don't have any improvement in outcomes. And then finally, beta blockers, we do see reduction in outcomes either with unstable angina or an actual MI. So these are also going to be recommended as one of the first drugs that patients will get, depending on their situation, as we'll talk about in a few minutes. So aspirin, the only contraindications would be if they had like a recent GI bleed or intracranial hemorrhage or if they had an allergy. But again, the main benefit here is going to be this decreased recurrent ischemia, reinfarction, etc. Nitrates, typically the patients will start with PO or sublingual nitrate, I should say, until they get into the hospital and they may require IV therapy. The big thing you want to watch out for is if a patient with ACS is developing hypotension, you'd want to avoid nitrates because that could actually worsen that. And then obviously be careful if they have a PDE inhibitor on board because again, they can cause pretty significant hypotension. Now, if the patient is not having significant chest pain, they may not need any nitrates depending on the situation, but again, no mortality benefit like you see with aspirin. As far as beta blockers go, typically you'll start with IV, either en route via EMS or in the hospital, and then convert them over to PO. And typically they'll be discharged on a beta blocker because we know these are going to provide long-term mortality benefits. Obviously, the patient comes into the ER and they're bradycardic and hypotensive. You don't want to go ahead and give them a beta blocker. You can wait until they're clinically stable and then start them up on that, and then with the goal of getting them over on a PO beta blocker. Now, morphine's another component that is a little more controversial. Certainly, if patients are not being managed well with sublingual nitrates, you can add on morphine as an opioid analgesic. This will help with the chest pain. But again, similar to nitrates, no improvement in mortality. It's only going to cause increase in pain management with analgesia. May be useful from that standpoint. So we've talked about the clotting cascade already, so let's see how we can affect that. So what do we do when we already have a stable fibrin clot? Well, basically we can use as a fibrinolytic or something to break down that fibrin. And so these are going to be typically agents that either directly or indirectly convert plasminogen over to plasmin. Plasmin is going to be the primary thing that's going to help to break down that fibrin into soluble factors that can be eliminated. The main things you're going to see here is that plasminogen is typically inactive in circulation, which is good because you don't want it to be overactive and cause bleeding and things like that, but gets converted over by this enzyme called tissue plasminogen activator, or TPA. So if you ever hear TPA, that's usually considered to be a clot buster because it converts plasminogen to plasmin and can break down that fibrin. Okay. Not only that, but it's also going to lyse things like fibrinogen, factors 2, 5, and 7. So very, very potent agents when plasma gets activated. There's another enzyme called streptokinase that actually will form a complex 1-to-1 with plasminogen that actually exposes these catalytic sites, and that's what interacts with TPA. So again, it's another kind of important component to it, which is we'll see when we talk about the different drugs here. So typically streptokinase your body's producing will help to bind that plasminogen, will uncover those catalytic sites, and then TPA in another product called urokinase here will help to bind that as well, and will cause that plasminogen to be converted over into plasmin. So what you'll see is there's a couple different products we have available to us, but you have things like streptokinase and urokinase. These typically are going to bind both circulating and fibrin-bound plasminogen. That's not super useful to us. We want to really focus on the fibrin-bound because that's where the clot is, right? I mean, we're likely to see possibly other side effects if you're just kind of binding up to plasminogen elsewhere in the body. And so things like TPA, retiplase, and this tenecteplase, as we'll see here in a second, only activate fibrin-bound plasminogen, and these are the primary ones we're going to be using in our day-to-day practice. Similar adverse effects, very similar responses. They can all be very effective at busting these clots, but you'll see that why we only use TNK, ACE, TPA, and retiplase most commonly. So all of them, the major thing we're going to see here is bleeding. You can cause very significant life-threatening bleeds with these patients if you're not careful. So it's important to understand what contraindications you want to avoid so you know which patients to avoid these in. And then you see a lot of allergic reactions associated with it. You have to worry about that. And then also some increased risk for ventricular arrhythmias, which if a patient's having an MI, they're already at risk for anyway. So this is really important. Anytime you see someone getting a fibrinolytic, either for a inclusive stroke or a ischemic stroke, I should say, or an MI, typically what you're going to find is they go through this checklist to make sure a patient does not have any contraindications. Again, so if they have things like aortic dissection, if they have surgery within the past 10 days or history of hypertension, these are all things, and again, this is pretty significant hypertension if the diastolic is greater than 110. So again, if you hit any of these contraindications, be checked off, you could not get the drug, right? Because the bleeding risk would be so high that it would outweigh any potential benefits. So one thing you'll note with these fibrinolytics, you still use it relatively commonly with ischemic strokes. You're using it less and less with MIs because most of these patients end up going to the cath lab. So again, that door to balloon time is an important metric. It shows how quickly you can get to a cath lab. So you may use it occasionally if you had a patient who says coding in the ED with an MI, could not get into the lab, or if you worked someplace where there was no easy access, then you might have to use these fibrinolytics more often. So I'm not going to talk about streptokinase too much, not really used in the US anymore. There's also urokinase, which is similarly not used. I just list them here just so you kind of have an idea of kind of the full spectrum of drugs you can possibly use or you might see occasionally. The main ones we're going to focus on include alteplase, or activates. We have retiplase and this tenecteplase. They have different sources where they're coming from, but again, most of them end up being pretty expensive. A lot of them are recombinantly made to mimic the tissue plasminogen activator we have in our bloodstream. You may see some other uses for these, including alteplase very commonly gets used for occluded IV lines that have, like, say, a clot built in them. You can actually give small doses of this through the line to help break that down and save your line, essentially. But they all have very similar activities and, again, similar bleeding risk associated with them. You'll note as well that certain patients are not going to really benefit from fibrinolytics because their increased risk for bleeding is too high to really compare to the benefits. So patients who are older than 75 typically are less likely to get a fibrinolytic because the bleeding risk is higher. And then symptom onset is really important as well. The sooner you get a patient in, the sooner they are to benefit from these fibrinolytics. Basically, time is tissue, and so they find that they have decreased efficacy as time goes on. So if you had someone who, say, was say 64 had a heart attack and they came in 24 hours after onset, like this would be less effective, right? And so you would not get that drug in a lot of those cases. Even with InSTEMI, the time frame is even shorter because it's less likely to be as much benefit there. So relatively few patients are receiving these anymore for MI because mainly they're going into to get a catheterization in a lot of cases, mainly due to things like intracranial hemorrhage, up to 1% risk. It's still pretty high for something that could be life-threatening or could affect your cognition the rest of your life. So again, big reason why we're moving away from these. As far as MI goes, typically you don't use a ton of 2B3A inhibitors unless they are going to percutaneous intervention. So if they're going to the cath lab, you may see these being used occasionally. So things like your tyrofibin, things like that. As far as the P2Y12 receptor antagonists, like our clopidogrel, also used oftentimes in conjunction to PCI, and they also will use them post-operatively after you put a stent in, right? So this is help with clot prophylaxis. And then patients will oftentimes get heparins like enoxaparin or just heparin itself in conjunction if they were to get a fibrinolytic drug or the antiplatelet drug. So a lot of times you'll see patients put on heparin drips during an MI, things like that, in order to prevent further clotting. Here's an example of what a stent placement would look like. Obviously, I have a balloon here that would expand this bare metal stent into the vessel to keep it patent. This is much more prone to have platelets come on and aggregate towards it. So because of that, that's why we'd use antiplatelet drugs like clopidogrel or that prasugrel, things like that, to try to prevent clots from happening here. So as far as treatment of InSTEMI, how that differs from the actual STEMI is that the treatment is very similar early on. You're still giving them oxygen, you're still giving them aspirin, things like that. But typically you don't recommend fibrinolytics. The bleeding risk is just too high versus the benefits. And oftentimes we'll use enoxaparin over heparin. It's based on some of the studies we have. And then additionally we use 2B3A inhibitors more commonly. So that's it for this section. If you have any questions, please feel free to write me and we can talk about it before next class if you need to, or we can have any questions answered at the next session. Thanks so much and I'll see you soon.